This is the Tox Course Podcast. Welcome back to the Tox Course Podcast. This episode was recorded just after we wrapped up filming the upcoming and highly anticipated Bites, Stings and Envenomation module with none other than one of the biggest names in toxicology and toxinology in the world, Professor Geoff Isbister. Geoff is a senior staff specialist and director of the Department of Clinical Toxicology at the Calvary Mater Hospital in Newcastle. He's research lead in the Clinical Toxicology Research Group at the University of Newcastle and Professor of Pharmacology in the Faculty of Medicine and Health at the University of Sydney. He's a world-leading expert on venom and antivenom research, having published over 340 research publications on these topics. In this episode, we talk about the origin of and the incredible ongoing work of the Australian Snakebite Project, the epidemiology of snakebites in Australia, and the practice-changing impacts the A.S.P is having on the modern clinical management of snakebite. We delve into the history and limitations of venom detection kits, or VDKs, and the reasons these are being phased out in a lot of places and may actually disappear altogether. We talk about what to do with snakes and spiders that get brought into the ED, and we go through a wide range of interesting and even occult ways people can present after snakebite, including collapse, syncope, and seizures. We also hear some of the more subtle, interesting, and humorous ways that people have run into trouble with snakes. Also on the panel are our other Tox Course expert faculty, Ingrid, Berling, and Nick Dafters. So without further ado, let's get into it. This is the Tox Course Podcast with Geoff Isbister. So welcome to our Tox Course chat on the couch with Geoff Isbister, the toxinology expert we've got on the Tox Course Module 4. We've just finished recording and we're wrapping up with this fantastic podcast. We've got a few questions we want to pick Geoff's brains about. So we're going to start, Geoff, by asking about the Australian Snakebite Project. This is something that I think a lot of people who work in emergency departments around Australia have probably heard something about, but might not quite understand the depth and breadth and significance and the origins of. So can you maybe take us back to the start and tell us about the Australian Snakebite Project?
Sure. So the Australian Snakebite Project started 2002, 2003, and the idea was to try and prospectively collect snake bites, to look at definite snake bites, so where we identified the snake at the time and then prospectively recorded the clinical effects, and then to look at antivenom dosing, effectiveness and adverse effects. And from that time, it's grown in terms of how do you collect all the snake bites or snake envenomations that occur in Australia. And that's been thanks to a large network of poison centres, clinical toxicologists, emergency physicians, and laboratories. And it's amazing how interested like a laboratory technician will get. And what we did was we would use us being called for advice about snake bites to then recruit that patient to a study. So the way it works is, unlike a lot of studies where initially we tried to get ethics approval at each hospital and get someone at the hospital to coordinate the study, which really doesn't work because everyone's busy in the emergency department and don't have time to do that. So we've set it up as a remote in the sense that all we want is to identify cases of snakebite and then just give us a fax number or an email, some patient details, and then we'll send you all the information about the study. And then you just fill out a consent form from the patient and then some data sheets. And then on the consent form, that's a consent also to look at the medical records, and we collect that. So in a sense, we centrally do all the work. So, which makes it easier. One way it works well, I think, is that most of the calls are taken initially by myself or another clinician. And it's that sort of payback is that, we give advice, help people, and then people are then happy to at least, get a consent done and start the process so that we can follow it up. And by doing that, we've collected, I think somewhere between 50 and 80% of cases across Australia. We oversample envenomed cases, and they're the ones we're most interested in. Those patients with envenomation or patient where there's a definite bite by an identified snake, even if that's non-envenomed. We don't tend to collect the multitude of non-envenomed cases after that. but we do for some of them because sometimes we don't know initially. And by doing that, so we really got collecting properly in 2005, and from 2006 we sort of have a constant recruitment now right through, and it's still going. And from that we've published now 34 studies, initially looking at each snake type. So we'd do a study on brown snakes or one on tiger snakes to define the clinical syndrome for each snake when we were clear that, what the snake was. The other part is we've developed a laboratory and we can measure in blood, so in serum, the venom of, as we've said during the day, the 8 major snakes. So that includes the 5 major groups so we have brown snakes, and in the tiger snake group we have tiger snake, rough scale, and the broad-headed snakes. Black snakes we have mulga and red-bellied black snake. Then we have taipan and death adder, and we have assays for all of those. And that's the way, if we don't get a snake identification from the actual snake, in the rest of them, we get blood sent to us. So that's part of the project as well. You'll find after you consent, we ask that blood can be collected, a serum sample that we will then contact the laboratory and get that sent to us. We no longer ask for a separate one to be done. We just ask, with any clinical blood collection, just ask for a serum hold to be done, and then we can organise that to be sent. Really from anywhere in Australia, labs have been really helpful in doing that. So that's, what it is. We put the data into a database and, we review that all the time. And then from that, we've run a number of studies. We've had like 2 randomised control trials nested within that, one of FFP and one of antivenom for red-bellied black snake bites.
Geoff, how do you find the reliability of the snake identification, without using the venom in the serum? How often do you reliably get a report of the snake from the clinical story?
From the clinical story, it's not always correct, and I mean really that comes down to Australian snakes. We have this amazingly clever naming system where we call one group brown snakes, and half of them aren't actually brown, and then we called another group black snakes, of which mulga or king brown is the most important snake, but it's not actually black. So what that means is that, when you're clinically looking after it, that it's a brown snake bite. No, it's a brown coloured snake bite. But we've certainly in Victoria, once we started looking at it, we realised that most cases are tiger snake bites. But we've certainly had some cases where patients came in, got a VDK done, came up positive for brown, and it wasn't until we did our assay we found in fact they were actually tiger snakes. And those 3 or 4 patients to this day will believe that they were bitten by a brown snake, whereas in fact it was tiger snake. So a clinical story can be problematic. Distribution will always help you. And now if they've got the snake, we've improved identification of snakes. So with phones and things, we often get pictures. And now with one of my postdocs who's a snake guy, and he has his snake network group. And so I just send him a picture and he'll go, I think it's this. And then within about 5 or 10 minutes, he goes, Joe Blow says it's this and such. He's the expert on this type of snake. And he says, it's definitely that. So we'll get a good identification in 90% of the cases now. And it's useful for the research, but it's actually more useful clinically if it's like, that's not a dangerous snake. You can send them home. It varies depending on, what it actually is.
And you mentioned the VDK for the Victorian cases coming up as brown snake, but it wasn't, it was tiger snake. Does that just speak to the unreliability of the VDK test kits? Yeah,
that's right. So the commercial venom detection kit is designed to detect venom on skin. So really only pure venom, not venom that's in blood, not venom that's in urine. So it's only sensitive to that. And it's supposed to tell the difference between the 5 major groups in terms of identifying antivenom. The problem is it's got a high false positive for brown snake. So you can rub it on someone who hasn't been bitten by a snake, and it'll be positive for brown. And that's where it's most problematic, because despite 30 years of education, people still do the kit in non-envenomed patients and then use the kit to say, oh, they're envenomed, we'll give them brown snake, it was never designed to do that, but that's, what happens. And that's why we get this high false brown. And that's where it's a problem in Victoria, where most snakes are tigers. And if you then go into a VDK, which is most likely to say brown, it just becomes confusing.
We might drill down a bit more on the VDK stuff in a minute, I think, because this is a really interesting area. Yep. Going back to the project, have you got a sense of prevalence or numbers of envenom bites or trends over time with that, or factors that influence how many people end up getting bitten or envenomed?
Yeah, so in terms of numbers, I mean, in the past it was always quoted that there was 3,000 suspected snake bites a year, and there would have been 500 envenomations. A.S.P would only get between 60 and 90 uses of antivenom a year in terms of patients where antivenom was used. Worst, I'd say we probably only get half of the cases in Australia. So even if it was half, we're still talking only 150 envenomations each year where antivenom is actually used. And I think we've, at some points we'll follow up, media cases. So if we see on the internet, someone's been bitten by the snake, then we will chase those up, go to the hospital. And often, even if people say, I've been bitten by a snake, we can get consent for them to be involved. So it's very rare that we find, a missed case, or someone will go, oh yeah, there was this case on the media. I said, yeah, we've recruited them to, the study. So I would say between 100 and 150 uses of antivenom or systemic envenomations each year. The number of suspected cases, if you then extrapolate that, it probably is around about 3,000. I mean, you've worked in Darwin. We know for Darwin that, there's probably about 3 to 5 uses of antivenomins each year, but there's about 70 to 80 suspected snake bites. And that's where it would be highest in hospitals that are seeing large numbers. So that'd be similar for hospitals like Cairns, Nambour, Lismore. More urban centres probably will have a higher rate of envenom cases, simply because they're retrieved there, and they, in the city you don't see many snake bites, from that point of view.
Yeah, I was going to ask you that about geographic distribution then as well. Is it true you read about most snake bites occur in sort of rural and regional areas?
I think to a certain extent. We've just looked at that for one of the studies. If we looked at, hospitals are either very remote, and then they're then regional, or then city hospitals. The very remote it was quite uncommon, and then remote. So we're talking, off the top of my head, about 3% very remote, and then only about 10% remote. And then for those regional hospitals, it's 20 to 30%. But even in major cities, it's quite high. And the reason for that is in the outer suburbs of Melbourne and Sydney. So there's a lot of cases for Sydney, Campbelltown, the western suburbs, and then again in Melbourne in the outskirts. Off the top of my head, Maroondah Hospital, there's lots
the
of
Dandenongs out there,
cases. So, it's not, and snakebite is about the snake plus the person. So yes, there's lots of snakes out in the remote areas, but there's not many people out there. So the chance of the encounter is actually quite low. Whereas if you've got a city outskirt where there's lots of snakes, there's lots of people, that's when it's, you're going to get a lot of bites. And that's the same, you said, does it change over time? And I think every year, about this time, the media will go, are we getting increased snake bites because of the bushfires or the floods or
Summer's
the drought or
climate change?
But it's like, well, it's summer and, it's heating up. Snakes come out then. So every year, yes, it happens now. And it happens when the whole lot of us humans go out there and encounter them. So yes, we do see lots in late December right through January, just because people are out and about. And that really doesn't change year to year. So if we look at across years, the there's not much change, and I'd say any of the ups and downs are probably more to changes in recruitment to the study than actual snake bites. But there's clearly that no snake bites, or not no snake bites in winter. But yeah, it's much less.
Drops off. Yeah.
And going back to recruitment and the burden on the patient, so really, like, aside from a couple of randomised control trials that you've had nested within it, that's really just a prospective observational study for the patient. They're not getting any treatment change. They're not having to give anything extra. You're just watching what happens to them against standard treatment.
Yeah, that's right. So, for both the clinicians and the patient involved, all we want really is the clinical information. Yes, one blood sample so we can then identify the snake. But no, we're in none of those are we looking at, or are we changing treatment outside of controlled trials? Yes, we sometimes look at treatment, or most recently time to treatment, but it's not something that we are controlling at all, and we just prospectively record that.
But from that data that you've gathered, you've been able to make recommendations to change treatment in the future.
Yes, that's right. So, I suppose one of the most controversial and important changes is the dose of antivenom. And that's not an intervention that we did. All we simply did was collect a whole lot of patients. We would measure the venom beforehand. So one was for identification, but one was to show there was venom in the sample. And then we would measure a post-antivenom sample, which we couldn't detect any venom in, to show that clearly enough antivenom had been given to bind all the venom that was in the circulation, as a way to show that's enough. And by comparing patients that only got 1 or 2 vials versus much larger ones, we showed that 1 or 2 was sufficient. And then we continued to do that as we the study has influenced clinical practice over time, not for an individual patient, but because, well, this is what we're showing. And we would change practice. And I think that's because, one, clinical toxicology is a small community within the country, but also because of the Australian Snakebite Project, people would be aware of that, and we could immediately translate that into practice. And that often I'll say, oh, will you recruit into the Australian Snakebite Project? They go, oh, yeah, no, we know that study, or they've read a publication, or they've heard about it. And I think, that's great. The study doesn't work without that support, from clinicians, and, that's emergency physicians, but it's also rural and regional GPs and junior doctors looking after snakebite.
Should we move on and talk about VDKs now then? Nick touched on it earlier. So you touched on some of the limitations and false positives and things, Geoff, and this is something, again, I think as a registrar, I didn't really have much to do with many snakebite patients, and relatively uncommon. Wasn't really until I went and worked up north that started seeing a fair number of people and actually started paying attention to what the VDK is and the utility or lack of utility in certain circumstances. So can you maybe take us back to sort of where VDKs came from and how they've sort of become a thing, and then we can dig further into it about the use of them and when we should and shouldn't use them.
Sure. So VDKs are based on a similar assay that we use. It's an enzyme-based immunoassay, but it was developed initially right back at the time of the Commonwealth Serum Laboratories, and so that's why it's become a commercial product of CSL and now Seqirus, which supplies the antivenom. And it basically has 5 wells that are for each of the different major snakes. Blank one, and then a positive and a negative well. In terms of it should be positive because it definitely, the test shows that, and then it should be negative. And its purpose was to determine which type of antivenom you give to an envenomated patient. So it was never ever, and it can't, provide the information to say that they're systemically envenomed, because all it's doing is detecting venom on the skin, which, snakes, even if, you may have a dry bite and there's venom there, or more commonly, there's nothing there, and then the test is becoming falsely positive. So that led to, when we've talked about antivenoms in Australia, there was this approach that we needed to identify the snake so that we could give the one monovalent antivenom versus worldwide, the more, well, we've got a polyvalent, we'll just identify a patient that's got systemic envenomation and then we can give them our polyvalent, and we're not so worried about which snake it is.
I think, is that because early on there was this concern about increased adverse reactions or something if you're giving polyvalent to someone who you could potentially identify a single snake to, and it was, the perception was, this sort of what I vaguely remember being taught, which is may or may not be actually fact-based, is the idea that narrowing the antivenom choice down was because of it was safer to give, or what was the rationale to try and whittle down to monovalent?
Yeah, that's exactly right. Is, well, let's just give a small amount of the one that is just for that snake type. And I mean, despite numerous studies looking at adverse reactions to antivenom, there's a suggestion that the larger volume ones do have higher reaction rates. But even in Australia, tiger snake antivenom has a unusually high reaction rate, despite being one of the two low volume ones. And then overseas, I mean, there was never, even looking at volume or even looking at rate of administration hasn't really shown a difference. So we've come around more to thinking it's, if a patient, we need to work out whether a patient's got systemic envenomation, and then we need to give them antivenom. And we don't want to do something where, we gave them the wrong antivenom because we were being clever, rather than, let's just give them antivenom. And and then we've shown, and one of the largest studies in A.S.P has shown that not a large number, but a significant proportion of venom detection kits are done incorrectly. So a large number are done in non-envenomed patients, which should just never be done. And in those, a small number are then positive for most commonly brown snake, and then antivenom has then been given to non-envenomed patients, and then some of them have had an adverse reaction, and when they were never not envenomed in the first place. So that's a large number. Then even from the envenomed ones, we're then getting false results. So people are giving the wrong antivenom or not getting, a result at all. So it really adds little to the treatment of patients. And we've shown that it's never going to be used correctly. So in a sense, it creates more problems than it's worth. And it's moved just to this similar approach in Australia to the rest of the world, whereas we focus on, is this an envenomed patient? And can we want to give them early antivenom, and all you may have then is a patient who's, vomiting and got a headache. They're clearly envenomed. Why are we waiting for kits to decide, is this a brown snake or a tiger snake? We just give them one vial of each, and you've then covered it. They get early antivenom. So not only does it delay treatment, it confuses treatment, and while we want to give more patients more envenomed patients antivenom, we're always going to give a small group of non-envenomed patients antivenom. But the last thing we want is a test that actually increases that group getting antivenom.
So, Geoff, we'll just wrap up on VDKs then. I guess one tip I got taught early on, even in a relatively high-frequency snakebite place like Royal Darwin Hospital, was the doctor should not be the one doing the VDK. If you're going to do it, it should be done by lab staff who are trained to do it and probably do these sorts of tests more frequently, because it's not like doing a full ward test or a dipstick on a urine, is it? It's quite a bit more involved. There's some timing and things involved about watching it closely and seeing which well changes colour first. So I think that would be a recommendation, is don't get tempted to start. If you've never seen one or done one before and you've got someone who's potentially envenomed sitting in front of you, that's not the time to learn how to do a VDK. And I think we were just talking offline as well that some states are actually removing them completely now in Australia. So I think it's a watch this space thing, that they may actually just disappear soon.
Yeah, that's exactly right. The problem was, 20 years ago, doctors were encouraged to do it, and then we did move it completely to laboratory. So, many here will have, Ingrid and Nick probably have not done a VDK, and also that it only gets done in envenomed patients. But despite that, it was still used. And yeah, it is a complicated test. You've got to add a reagent here and do that. And, we're not good at doing that. And then you have to watch it closely because it's the first well that goes blue, that's the one. And if you wouldn't want to be looking at your patient, far more important to look at the well. So it was very problematic from that point of view. The other thing about it is that it had an expiry of 6 months. And so hospitals would keep these kits right through winter. So often they'd be keeping a kit that they then had to throw out. And I worked out actually in the Hunter, New England area, we're probably spending about $20,000 a year just on VDKs for every hospital to have one to make sure they didn't expire. And we knew for that, our area health service, at most we would get 3 or 4 severe envenomings a year. And to me, $20,000, and that's not including the antivenom that we have to keep, was really not a good payback from that point of view. So not only are there a whole lot of clinical reasons and safety reasons not to have them, economically we will save a significant amount of money by not stocking them.
So Geoff, it wouldn't be unusual for patients to bring in venomous creatures into the ED that have bitten them. It's happened to me in Hunts, New England. It's also happened up in Darwin. So if you have a snake in a polystyrene Tupperware tub, which is one of the more common things, what do you do with it apart from terrify the nurses? Is there anything else you can?
Well, I mean, fortunately and unfortunately, people do bring in snakes. We would definitely say do not bring in live snakes. However, I mean, that's clearly at one point a good emergency department scenario of a patient who brings in the snake and goes, look here, drops the snake in the department. What do you then do? The simple solution is get a garbage bin lid and chuck it over the snake. It's the easiest way to solve the problem there. So yeah, we don't want live ones. If it's a dangerous snake, you can put it in the freezer or the fridge but clearly most states have a service. So in New South Wales, we have wires. You just call them to remove the snake, and most of them will also then be able to identify it if it's a live snake.
So it's a wildlife service.
It's a wildlife service. I can't remember what it stands for in New South Wales, but each state will have a different one. And lots of emergency departments will also have, someone that they call for snake identification, or particularly like Darwin or places that are seeing a lot. If it's a dead snake, then pictures of that can be useful, because if it's there, then we can get an identification, but we certainly wouldn't be saying to people go out and kill the snake. And often
that's a risk factor for getting bitten more than once, is the person who gets bitten and then says, oh, I better go to hospital. They want to see the snake, so I'll try and kill the snake. And then they get bitten 2 or 3 more times trying to kill it. Or their friend tries and kills it and the friend gets bitten as well. I've definitely seen that.
Yeah, exactly. That's right. And, but people often take pictures of the snake that they don't bring in, even if it's live, at a distance, that can still be useful. But, that's never going to be a priority. We'll use that information, but we would never say, oh, why didn't you bring the snake in? That's not, helpful.
Is there never an argument in terms of just sourcing more snake venom to generate antivenom, or is there not really a shortage of snakes to provide enough antivenom in Australia?
No, snakes aren't an issue. There's Venom Supplies in South Australia, keeps a large number of snakes, and they supply almost all the venom, between them and a small amount from the reptile park in Gosford. So there's never been a shortage of snakes. There certainly is of other, so funnel web, there is often a shortage, and they will still collect live funnel webs, even through the Hunter New England Pathology Service will collect the spiders so that they can then be milked. And others are, and at one point, redbacks, people would try and get them, not that we need them for the antivenom anymore. So yes, snakes aren't an issue, but definitely funnel webs.
And with the funnel webs, if someone's brought them in a Tupperware box, they'll eventually asphyxiate unless there's a hole in the box. Is that right?
You can put a hole in it, but most things aren't that airtight. And to be honest, funnel web spiders can actually survive. One common place to find them is in the pool. And what they do when they fall in the pool is they pull a bubble of air around them, and they'll survive for a number of days. So same in a container, they will survive. So, you can put holes in it, but,
small holes.
It's small holes. If it's in a container, then, Yeah, and it's reasonable to bring that in. Even for if you've been bitten by a spider, it's relatively safe to catch a spider and to bring that in for identification.
So the funnel webs don't jump and they don't see well, do they? So you can put something over them and then...
Yeah, most spiders are reasonably easy to collect just by putting something over the top and then sliding a piece of cardboard underneath and flipping it over. You can put them in the fridge because that'll slow them down. Don't put them in the freezer unless if it's just a spider that's bitten you, then putting them in the freezer is another safe way, because that will humanely kill the spider and then it can be identified. But not if you're trying to bring in a funnel web to be milked for venom.
Don't wait for it to freeze either.
That's right.
Don't put it in the freezer and go to bed. And so I'll take it in the morning when it's dead, because you might be joining them
That's exactly
in the process. I guess another tip I had is for people who do retrieval work. Generally, most retrieval services don't want you bringing the snake or the envenomating, is that a real word? The venomous creature on the plane with you or on the helicopter, because unless it's chopped up into little pieces and you're 100% sure it's dead, there is a chance that when they go, yeah, it's definitely dead, here's the pillowcase with the snake in it, that it may not be dead and could come back to life on the plane and bite you on the plane. And also they stink. Snakes don't smell very good, and you'll stink out the plane as well. So generally, I think in that setting, I think it's probably more useful to actually take some photos.
Yes, that's right.
At the place where you're picking the person up and then ask them to dispose of it rather than carting it all the way in with you. And there's been various retrieval jobs where people have brought stuff from scenes that then gets misplaced, and then you might forget that you brought the snake because the patient's getting sick or whatever, and it gets stuck under the seat of the plane, and a few days later people, what's that smell? And they've got to pull the whole plane apart and find the dead animal in the plane. So yeah, generally don't bring snakes with you.
And the other thing about dead snakes is that we certainly have cases of envenomation from dead snakes. So
Yes.
And people do odd things with the snake. There is venom still on their fangs, and you can still inject it and get envenomation. So yes, even though they may not come back to life, but
they can still poison you.
They can still affect you in that way.
So obviously, because of the Australian Snakebite Project, you get called about a lot of snakebite cases. Are there times when people have been envenomed by a snake and they don't know they've been bitten?
Yes, I mean, I wouldn't say it's common, but certainly we worry about that, particularly for brown snake. So one thing we haven't talked a lot about is Australian elapid fangs are actually quite short, and the shortest snakes are brown snakes. So they're literally 2 millimeters long. That's compared to, say, funnel web, whose fangs are 4 or 5 millimeters. So they're very, very small. When they bite, you may not feel the bite. And sometimes you may not see a bite even though you've got envenomation. So you can very easily have a bite from a brown snake if you're walking through long grass or somewhere on a farm, don't know about it, you won't feel it, and then they may then present with collapse or seizure. And certainly a case in northern Queensland was exactly that. A teenager presented to the emergency department of Townsville Hospital with a seizure, and and then they got this history of them just walking through the farm. One of the emergency physicians said, well, this could be a snake bite, did a set of coags, and sure enough, they had a severe coagulopathy and, picked, a collapse, syncopal episode as being a snake bite. So that's probably the commonest time that you get the sort of occult snake bite.
And I mean, the pathology results that you get for typical VIC, venom-induced consumptive coagulopathy, are pretty remarkable. It's not really like you can confuse it with any other presentation. So there'd be some value in doing coags in an undifferentiated syncope or seizure.
Certainly if there's anything in that certainly if they've come in from, I was going to say from an office, but, we have a collapse case from a guy that was in an office and was bitten by a snake. They knew it was that. But, I think it's completely reasonable. And you generally, in 80 to 90% of cases, they have unrecordable INR and APTT, and they have no fibrinogen, and they have very, very high D-dimers. So this isn't, their INR's 1.5 or 2.
And I think to add to that, those sort of odd anecdotes of potentially not obviously snake-prone environments, there's the classic ones you talk about, like a farm. I've heard about people working in orchards, those sorts of things, or sort of river or water adjacent areas, yes. Sometimes snake habitat. And then there's the obvious, the bushwalker or people at a campground. But there was a couple of cases in Melbourne last summer. There was one guy who was jogging along the bike path next to the Yarra River, and there was just some long grass on either side. This is in suburban Melbourne, and collapsed. And of course, what do you think when you hear, there's a 40-odd-year-old guy out on a 5K jog who's collapsed? The first thing you think is a cardiac arrest. He's had a big STEMI. And I don't think it was until he woke up in ICU a couple of days later and said to everyone, I got bitten by a snake, don't you, that they actually put it all together despite his really abnormal blood tests and things. So I think that's important just to think about that backstory. And if you get an ECG on someone who's collapsed and or had an apparent arrest and it's completely normal, you've got to stop and go, well, hang on, there's something else going on here. And you may not think to routinely order something as simple as a coags on those patients, but it's a pretty easy test to do that could give you that really early clue. And is there there's obviously the dramatic end of the spectrum. Is there sort of less dramatic ways people present? I know the redback bites for spiders, I know people can just have funny joint pains and limb pains. What about snake bite? Is there other sort of atypical abdominal pains or limb pains or things that people will come in with?
I'm trying to think of other, when they present without a snake bite. I think the only other one I can think of is mulga snakes, where people are bitten at night when they're sleeping, and often that's in warmer areas where their toes are out, and it's thought that because they're wiggling their toes, the snakes bite them. So there's been a couple of cases of that, and that may not get picked up again as a snake bite because you may not wake up. You may then just get up in the morning feeling unwell. Worldwide, classically, so crates, which occur all through South Asia, right through India, Sri Lanka, and into Southeast Asia, they almost only cause bites at night in people who sleep on the ground. So snakes come into a warm body at night, someone rolls over, gets bitten by them. Again, they're a snake which, with small fangs, the patient may not even wake up. And so in the morning, they'll get up with ataxic as they're beginning to develop their neurotoxicity. And it's so diagnostic, it's almost the only way you can be bitten. But these snakes are docile during the day. You can basically pick them up and you're not going to be, you won't get bitten by them. I'm not suggesting doing it, but they essentially have to be rolled on to be bitten. And the problem with this is we've got a presynaptic neurotoxin. By the time they turn up to hospital, even when the diagnosis is finally made, they're usually about to be intubated and ventilated for that. So yes, I think being bitten at night, crates through Asia, mulgas rarely, but it's not actually a common snake bite in Australia. I think that's the only one. I think collapse, as we've talked about, is. I can think of it. There's the case in Melbourne. One of our first cases in A.S.P was a guy who decided to go running in 45-degree heat, out in Cobar, middle of West, collapsed, and then so no one ever got a history. Came into hospital. He was also hypothermic, so they thought he had DIC from hypothermia. And once again, it was the retrieval doctor this time who said he's had coags done and they're really abnormal. Is this really just the hypothermia, or could he have been bitten by a snake? This is out in the middle of
I think that's a really important differential to put in, because we definitely had a couple of patients up north who were sort of naive to the environment up there, fresh off a plane, going out work on a mango farm, then get found collapsed out the back and between the mango trees in 35-degree heat and the build up and 100% humidity. And they're coming in there hot already, they're hypothermic, and it was very easy to go, it's just heat stroke. But I think that's probably a really important differentiator, isn't it? If they've only been down on the ground for an hour or two before they've been found and they come in with acute hypothermia, they're unlikely to have they'll be going into DIC by that point and having a coags off the scale and that sort of stuff, are they? It's too early. Whereas if you do a coag and the INR is 8 or 10 or unrecordable, it's almost sort of pathognomonic, isn't it?
It is.
If that was heat stroke, they'd be dead. Like it's a different mechanism.
Exactly, that's right. Yeah.
I think, I mean, for me, the concern is we've got a lot of doctors, initially like myself, who don't necessarily know much about envenomation when you first come to Australia. We've got doctors from all around the world. And then syncope as a diagnostic presenting complaint, particularly in the elderly, is quite common. So you get a lot of elderly patients who've syncopated in the garden. And unless you force yourself to have, a brown snake envenomation on the differential, it's just too easy to miss, I think. So it kind of does need to be added to every differential list for the collapse, particularly outside, or the gardening old person that the wife finds in the veggie patch.
The other one I've heard about is people collecting firewood or stacking up the wood pile outside the house. That garden sort of related, or getting something out the back of the shed. So I think they're sort of clues. If you hear that element in a history of gardening, a shed, a wood pile, outdoorsy kind of not particularly strenuous environment where you wouldn't expect someone to just suddenly keel over, it's probably an important element to the history to think of.
Yeah.
So can we make snakes any more scary? You can be bitten. You don't know you've been bitten. It can happen at night while you're sleeping.
and while you're walking in your office.
And they can come. I mean, a common. There's been a number of cases now of red-bellied black snakes that have been. Shop owners have been bitten by them because they've been sent their box of bananas, and they open it and there's the snake that's in it.
I'm starting to want to look under my chair.
We certainly had a case in Sydney, one in Newcastle where that's happened. And they're the people who've been bitten by it. So, in fact, there's probably a lot more where this occurs.
Yeah.
You also hear about them crawling up under the bonnets of cars, and then people open the bonnet and there's the snake there.
Yeah,
or they'll be driving along the highway.
Well, one morning at Maitland Hospital, we literally opened the linen cupboard in the main ED and crushed a red-bellied black snake that had been covered up in the linen cupboard because there was a sort of external door close to the cupboard. And it really did smell quite bad. I think it had not long since eaten a kind of rat or something. And so it was this half-alive snake, and luckily we had some rural-based nurses that were very competent to get rid of the snake.
I guess, well, maybe that might be a good segue point then to talk about some of the more interesting calls you've had. And Ingrid, you two working for the Poison Service, about medical people ringing up with questions about snakebite-related circumstances that are a bit crazy.
Yeah, well, I think there's a few funny calls that you can have. Certainly my favourite call that I've had is from a person whose dog was bitten by a snake, who was then bitten by their dog, and then the local GP was calling up to find out whether there was any chance that the patient was envenomated from the infected dog. Not something I've heard of occurring. I was quite comfortable to say that was not an envenomation.
You probably didn't need to ring Geoff about that one.
No.
Oh, that's good.
But I mean, I think that's actually a common scenario. Well, not in terms of being bitten by the dog, but often there is the snake bites dog, human tries to protect dog, human then gets bitten by the snake, or either both. So often, we certainly had cases. There's even been a death from a guy who was getting a snake away from his pets. Also, cases where snakes have been taken, like where there's kids near snakes, and so adults have tried to remove that snake and got bitten in the process.
Yep. And what are the more entertaining ways people have been bitten by a snake?
Well, yes, entertaining, a bit sad sometimes. So certainly, death by or suicide by snake, or threat to suicide by snake has been, we've at least reported 2 cases of that, of someone holding a snake, threatening to, get the snake to bite them. Also, people using snakes to threaten other people as a weapon. And certainly we had one of, police being, accosted by someone with a snake. And then the really unusual ones, I do remember one case, and I think this was in Western Australia, where the snake had been run over, and this guy then pulled up to get the snake because he wanted to cook it, but managed to get bitten by the head of a dead snake in the process of trying to pick it up. So, it's...
I think there's one I had, a colleague of mine told me about when I came onto a shift that morning. It had a young guy who'd wanted to go mountain biking and left his camelback, the backpack with the big long straw outside with his biking gear overnight. The next morning, got up while it was still dark and just threw his camelback on and took off on his mountain bike. And it was a bit hot and he got a bit thirsty and he reached for the camelback straw and put it to his mouth and felt this sharp pain on his tongue and looked down and there was a snake that had wrapped itself around his camelback and he put the snake head in his mouth and got bitten on the tongue. Then we thought that was a pretty good diagnostic test for a non-venomous snake, that the fact that he managed to ride home, come into ED and was still alive an hour later, that it hadn't had this direct injection into his like intralingual envenomation. And we thought we could pretty much say we don't need any blood tests, mate. I think you're going to be fine. But that was the poor guy got a terrible fright.
So to wrap up, looking at Australia as a whole, if you're a health practitioner anywhere in Australia and you get a patient with a snake bite, are there any take-home messages you want people to cling to?
It's a good question, Nick. I think the important points are you need to determine whether the patient's envenomated or not. That can be tricky. Sometimes it can be quite straightforward and quite clear, but it can be tricky. Call a friend. We have a poison information centre that covers all states of Australia, all states and territories, and best to involve someone else. Time to antivenom is important. I wouldn't delay with a VDK. And if you do involve the Poison Centre, then it does assist us to enrol patients in the Australian Snakebite study that Geoff's involved with.
Yeah, I think it's what we have had in the last 10 or 15 years is the Australian Snakebite Project's improved our knowledge of snakes. But I think more importantly, because of that being involved with the Poison Centre and the changes in the Poison Centre, that you now can get a clinical toxicologist in any state. You can get the best information possible at the time, doesn't matter where you are. And because antivenom is in almost every hospital, you can then treat that patient immediately with expert advice.
Look, that's been a fantastic chat, everyone. Thanks so much for your input, especially to you, Geoff. We really appreciate you being in the ETM studio and the ToxCore studio for the filming of Module 4. And if you're interested in learning more about this, we go way down the rabbit hole and into a lot more detail about bite, stings and envenomations. We go into a lot of detail about antivenoms and how they're made, how to use them, adverse effects, all those sorts of things on multiple different types of bites and stings and envenomations, including, correct me if I'm wrong, so we cover spider bite, snake bite, a huge range of marine envenomations, and a couple of other creepy crawlies of ticks and scorpions and centipedes and those sorts of things. So the Module 4 is it's really our most comprehensive and in-depth module yet, isn't it, for the Tox course? So keep an eye out for it. And we look forward to seeing you again on the Tox Course podcast.
So we hope you enjoyed this episode with Geoff sharing a small part of his encyclopedic knowledge on snake bites and envenomation. As we mentioned, this is the preview for the huge new Tox course module on bites, stings and envenomation, which anyone working in Australia in the pre-hospital, rural and remote, emergency department and even ICU settings really should sign up for. We don't just cover snake bite, we also cover spider bites in details, as well as a huge section on marine envenomation and a couple of other creepy crawlies that can bite, sting and envenomate you. So head over to etmonline.com, you can pre-register your interest for this module there, and if it's out by the time you listen to this, you can just sign up straight away. And I can't recommend it highly enough. Thanks for joining us, and we'll see you on the next episode of the Tox Course podcast.